Hi everybody, my name is Sarah Kopic and today I'll be talking about lower limb amputations. What is lower limb amputation? It's when they surgically remove a limb that has unhealthy tissue in hopes to salvage the remainder of the limb and make you be able to walk again, hopefully. The causes for amputation are peripheral vascular disease, which is also called PVD. That's the main cause of lower limb amputation. There's and the most common cause of PVD is atherosclerosis, which people with diabetes are at a higher risk of developing. There's also severe injury, cancerous tumor in the bone or muscle of the limb, serious infection that doesn't improve with antibiotics, and neuroma. Alright, there's a couple different types of lower limb amputation. We have below knee and then above the knee. For below knee, we have transtibial amputation, which is the most common type of amputation. It's through the shin bone. With this kind of amputation, you have a lower risk of serious post-operative complications versus transfemoral amputation. Walking is also more successful with this amputation versus transfemoral amputation. The other ones that we have are toe amputation, which is generally caused by poor blood supply to the foot, which is also from the blockage, which is caused by PVD. And then you have transmetatarsal amputation, which is through the long bones of the foot. This amputation allows high level of functional mobility because the major muscle attachments are preserved. For above knee amputations, you have transfemoral amputation and hemipelvic amputation. For transfemoral amputation, that one's through the thigh bone, and it can lead to significant loss of muscle control in the hamstrings and the quadriceps, making walking very difficult in the future. Then you also have hemipelvic amputation, which is through the hip joint and part of the pelvis is amputated. Walking is extremely difficult because there's no residual limb. Alright. Epidemiology. We would do, there's 30,000 to 40,000 amputations are performed annually just in the United States alone. 80% of the lower limb amputations are caused by PVD and diabetes. And among people with diabetes, the lower limb amputation rates are highest with men, African Americans, and the elderly. Pathophysiology of lower limb amputations. Wound care is very important for the residual limb. If wound isn't treated or cleaned properly, it can lead to infection, skin breakdown, or death if you don't take care of like an infection that gets in there. Also, the energy required for walking is inversely proportionate to the length of the limb that's remaining. This can contribute to sedentary lifestyles of amputees. Even non-vascular amputees have had higher rates of CVD, hypertension, and adult onset diabetes because of the sedentary lifestyle that this creates. For average transtibial amputation, the energy required to do the daily things that we would do as non-amputees, it takes 25% more energy. For transfemoral amputations, it takes 65% more energy than it would take for a non-amputee to move. So that would be why the sedentary lifestyle is so prevalent, because once you increase like the difficulty of moving, people aren't as willing to exercise or do the things that they need to do. Phantom limb, this is when you have a vivid perception of the area where the amputation occurred, as if the leg or the arm, in this case lower limbs, were never removed. And with this, you would get mild or extreme pain. Studies suggest that 90 to 98% of amputees suffer from phantom limb for days or weeks after the surgery. Alright, PVD, peripheral vascular disease. It's a slow but gradual advancing circulation disorder, and it's caused by the disease of blood vessels outside the heart and the disease of lymph vessels. Arteriosclerosis is the hardening of the arteries that causes the blockage. The blockage narrows the flow of blood, which carries the nutrients and oxygen to the limbs. The most common locations are the femoral arteries and the popliteal arteries because they are the major blood supply to the legs. Symptoms of PVD: intermittent claudication, leg numbness or weakness, weak or no pulse in the legs or feet, change in color of the legs, coldness in the lower leg or the foot. An intermittent claudication is the condition in which cramping pain in the legs is induced by exercise, and it's typically caused by the obstruction of the arteries, which is the arteriosclerosis. So exercise with PVD, pain is caused by that intermittent claudication because it's exacerbated by exercise. However, supervised exercise programs are recommended as the first mode of therapy for PVD patients, because exercise is highly effective in increasing the leg circulation and reducing the pain that is caused by the intermittent claudication, but sometimes people aren't as willing to do the exercise because it does cause them pain in the beginning. But if you keep up with the exercise, the pain is decreased and because the circulation is increased. Alright, on to my case study. I have a 25-year-old male. He is 182.88 centimeters tall and 83.91 kilograms in weight. He was active before his accident, and the accident is what caused, it was the reasoning for the amputation. He is a smoker, but he has no personal history of cardiovascular diseases, or he doesn't have any family history of cardiovascular diseases. His HDL levels are 65 milligrams, and his LDL levels are 145. He did have a transtibial amputation caused by a traumatic accident. His goals are to increase his balance and his ability to walk comfortably with the prosthesis that he was given. Risk stratification and group. So he's a smoker, so that adds 1. His LDL levels are high, which adds 1, but his HDL levels are high, which is good. So he has he's at low risk because he has 2 positive factors, but he also has 1 negative factor, so he only has one going against him. So he's at low risk still, being under 2. He's asymptomatic for disease, and a special consideration is that he had the below-knee amputation. Exercise testing that I would do for him is for muscular strength testing. I would do for upper body a 1 RM bench press because, and I would do it on a machine because of the balance issue that he would have because of the prosthesis. For lower body, I would do a 3 RM single leg press. I would do it 1 on each leg, the single leg press, because of you would like to compare the strength of each leg, the one with the prosthesis and the one without. For cardiovascular testing, I would do the bike ergometer test. I would do this because of, again, balance, so he could still be able to stay on there without having the worry of falling off or anything. For balance testing, I would have him do the balance board test. I would also have him be near either a railing or a wall or something that he could grab onto with spotters around him in case of a fall. For flexibility testing, I would do sit and reach. And for his range of motion testing, I would use the goniometer. For his exercise prescription, for muscular strength, I would start with 2 days a week and eventually progress up to 3 days a week. I would have him do 60% of the 1 RM to start and then again progress to 80% of 1 RM. I would have him do 2 to 3 sets of 10 to 12 reps. For upper body, I would have him use machine weights because of the balance issue that he would have with the prosthesis and getting used to it, and eventually maybe he could increase or progress up to the free weights. You would just have to see with progress. For lower body, I would have him start with resistance band exercises on the table and then have him progress to the standing exercises. For cardiovascular, I would have him start with 4 to 5 days a week and progress to 6 days a week when he was comfortable. Start with 40 to 60% of his VO2 max and then gradually increase to 60 to 80% of his VO2 max. 30 to 40 minute increments for time, but I would have him split it up as he feels comfortable, as he needs to. In the beginning, obviously, he won't be able to do the full 30 to 40 minutes like completely at one time. He would do walking on treadmills, he would do some stationary biking, and then he could progress to the elliptical. The elliptical would be a little harder because of the balance again. I wouldn't have him do running because of the type of prosthesis he has. With most of the prostheses, you aren't able to run because you don't have the range of motion in your heel. So he wouldn't be able to ever progress to that unless he got a different prosthesis. For balance, I would have him do it 4 to 5 days a week because this is very important with amputees. I would have him do it until a mild discomfort, and I would have him do 2 to 3 sets each day that he did it. I would have him do weight transfer, and at first you would just shift your body weight back and forth, and he could progress to using weights with it. He could move his weight from one side to the other and vice versa. And then he could do single leg stands. He could do obstacles, and you could progress the obstacles from harder to less hard. For flexibility, I would have him do 3 to 5 days a week to mild discomfort, 3 to 5 reps with 30 to 60 second holds, and he could do static stretching and PNF. In conclusion, PVD is the most common cause for lower limb amputations. Nearly half of the individuals who have an amputation due to vascular disease will die within 5 years because of the sedentary lifestyle and their likelihood to get the cardiovascular diseases. And that's why exercise is essential, because you need to live a healthy lifestyle as much as you can to prevent from these diseases and prevent the risk of getting a cardiovascular disease. And these are my references. Thank you.